This week, we're really pleased that we've going to have Devon Patel. So he's one of the consultant cardiologists from Barnet, and he's going to give us an update on cardiology complications related to COVID. Etiquette, I think we're all used to from Microsoft Teams, just if you could stay unmuted. If you can stay on mute and just unmute if you've got a question to ask, or to use the chat function, and Anisha and I will try to help look at that as time goes on, and we'll try to answer all the questions. And if we don't answer anything, it gets looked at afterwards, and we'll try to bring feedback to subsequent sessions. We're really happy also to welcome Suzanne Lever. So she's a much loved member of the medicines management team in Barnet, and she's taken over as Assistant Director for Medicines Management from Colin Daff, who recently retired. She's going to have a regular 5-minute slot at these meetings to give us an update on drug availabilities, alternatives if we're struggling to find suitable drugs, and local spending on high-cost drugs and national updates. And we know from you find these really helpful. So we're really pleased she's going to be giving us 5-minute updates. As ever, we're going to hand over to the Federation and to have an update from them, and then pass on with the rest of the meeting. So thank you very much, and over to the Federation. Thanks.
Thanks, Charlotte. Thank you for the introduction. Well, I just want to say hello to everybody, and it's a shame it's a bit of a miserable Wednesday afternoon, but hopefully we can keep you entertained for the next hour or so, or 45 minutes. Just a quick update from us. Next slide, Hani. Just around the AAC. The AAC will continue in its current provision, covering the Monday to Friday and Saturday and Sunday until the end of Monday bank holiday. From the 1st of September, there's a pan-NCL solution that we're working on. And as soon as we have that, we will send out communications. The plan is to continue the hours that we are providing, but it will be done through a pan-NCL approach, and continue to provide the home visiting service as well. So yes, just watch out for any more comms around that and the changes. Next slide, please. So just an update on our services. The EHS for the practices that are currently using the Federation continues, and we are loading the appointments now 2 weeks in advance. There are a mixture of GP, nurse, and healthcare assistant appointments. So please do look out for your own appointments and use them. I know that it's been variable, so please keep your receptionist updated on those. And I think they're really valuable face-to-face appointments, that particularly the healthcare assistant ones and the nurse ones. The anticoagulation service, which is running with the use of pharmacists and GP backup. So any patients that you want to move into the community through our services, Thank you. So just a reminder, you just need to send the referral form, and it is on Bar Global. And the last slide is really just an update on the activity, Hani. Just current EAS activity, showing that we are in August pretty much on track for the current activity. So we'll hopefully still aim to have provision of appointments, particularly over autumn and winter, to try and manage and stem the demand. That's really the update from the Federation. Thank you very much. I'm going to hand back to Anisha.
Thanks, Anuj. Hi, everyone. I just thought I'd give a quick update today on what's been happening in the Training Hub. In particular, I just wanted to let you know about some fellowships that are available out now, available to apply for. So there are some London-wide plans to develop an out-of-hours GP fellowship, and this will be combined with a salary job within a practice of between 4 to 7 sessions. So they will be doing their salary job as well as their out-of-hours fellowship time. So if your practice is recruiting in the next few months and you're happy to take on a fellow, please contact Mandy Claret. At some point during the meeting, I will post all of these contacts in the chat. So please contact Mandy and she can give you some more information. Similarly, there will be some newly qualified and mid-career GP fellowships coming out between now and January, the information of which is on the Training Hub website. Again, I will post the link. the Training Hub is really happy to have already appointed 2 newly qualified GPs to the Medical Education Fellowship, which we run jointly with UCH Medical School, and that's going very well. And we've also appointed our first mid-career GP fellow, who will actually be joining us on the GP training scheme to facilitate one of our small groups. Just a little update also from our pharmacists. So we have now over 30 practice-based pharmacists working across Barnet, and that's compared to about 4 or 5 that was working 5 years ago. So we really have come a long way. Our pharmacy leads in the Training Hub are Famida and Sheena, and they are currently establishing a peer support group for our pharmacists to attend. And that's just a safe space for them to offload about any tricky cases or discuss any issues. So the next meeting is scheduled for September. I think there are 2 dates, 15th and 29th, and that will be run by Dr. Lisk, who will be discussing the very important topic of polypharmacy. So if you do want to encourage your practice pharmacists and your PCN pharmacists to attend, I think that would be something that would be very valuable for them. And Famida is the person to contact. So again, I'll post her information in the chat as well. I think she's encouraging pharmacists to bring along tricky cases. I think we all have tricky polypharmacy type cases that we can help our pharmacists to choose. So do encourage those to attend. Speaking of pharmacists, there is an annual immunisation and flu update, which is being led by Jackie and Amita, our nursing leads, and that's happening on the 10th of September. I think there has been some comms already out about that, but just to make you aware that the pharmacists are being invited for the flu update as well, in case they're involved with the flu programme. And then the last thing to say from the Training Hub is that I think everybody's aware of the care home supervision project that's currently going on, which is basically a discussion group for our care home staff to engage with. And just to say, please remember to promote these sessions to the care home staff. We've had excellent feedback so far. So we've had 93 attendees from over 35 care homes attending across the sessions that we've already put on, and with most of the feedback being 9 out of 10 or above. So I think care home staff are really benefiting from this. So please do encourage the care homes that you look after, perhaps doing your virtual ward rounds, to attend. If you want any specific links, they are PCN based, those groups. If you want any specific links for your PCN, please feel free to send me a message and I can send you them. I think that's it for me. So I will hand over to Suzanne Lever now from Medicines Management to give us an update.
Hello, thank you very much. So I'm Suzanne Lever, Head of Medicines Management, and I thought I'd just take a few minutes to give you an update, mainly focusing on the Medicines Optimisation Enhanced Service. Next slide, thank you. Just to also let you know that with regard to EPS, Barnet has done extremely well. In June, over 96% of forms were sent electronically to community pharmacies, which is excellent. It's higher than the England average and higher than the NCL average as well. So thank you very much for that. With regard to Medicines Optimisation Enhanced Service, this week, your practices should have received letters regarding the payment for last year's service, which will be with you by the end of September. For this year's Medicines Optimisation Service, the budgets haven't been set yet. That's not an NCL issue, it's a national issue due to COVID. But regardless, we are completing our annual visits and we're giving practices individualised targets. The key message really is please contact our team if you have any queries. We've set up an NCL generic email address. We've got telephone numbers, or you can contact our team directly. We really don't mind. But please, if there's special requests or unlicensed drugs or anything that you're not familiar with, ask us first. Scripts, which is another area where we do have a large number of savings. So please make sure all your prescribers have access to this one. Any problems, please contact me. And for the 2021 service scheme, all practices will have to nominate an antimicrobial stewardship champion and participate in an audit to be able to participate in the scheme. So why antimicrobial stewardship? I'm sure as a national priority, CQC look at this, it's in the DES, so it really is an area to look at. Actual prescribing of antimicrobials, Barnet is pretty good at general prescribing per population. We are lower than national and we're lower than all the targets. But where we are higher is actually our broad spectrum. The graph on the left-hand side shows Barnett's use of, it shows NCL Borough use of broad spectrum antibiotics. That's cephalosporins, quinolones and coamoxiclav, and that's as a percentage of all antibiotic items. And Barnet is really the only borough that's higher than the national target, which is below 10%. On the right-hand side, you can see that actually I've broken out Barnet use of the broad spectrum antimicrobials over the year. And as we can see, actually, we were doing really, really well. Even in the winter months, up until February 20, we were actually becoming below the national target, and then COVID struck. So, and things were reversed. But hopefully that will be a temporary blip. My key message here is, please, would you refer to NICE prescribing guidance? It's called Managing Common Infections, and that is on the intranet. It's on the JFC website. You can get it by just Googling Managing Common Infections. It has advice on diverticulitis, impetigo, all different areas, UTI, and it's quite useful to look at and to refer to. We've also have some Barnet Borough antibiotic audit packs, which we developed with Penshurst Gardens. Just to say, Penshurst Gardens were one of the higher prescribers, and since doing all the audits and participating, they have actually worked really hard and actually are now under the national target in their broad spectrum use. There's also the RCGP Target toolkit as well, which provides audits and patient leaflets in all different languages, which might be helpful. So that is all from me. If you have any queries, please don't hesitate to contact me or any member of our team. We'd be more than happy to help.
Thank you so much, Suzanne. Thank you for that very helpful update, and we look forward to your regular slot at our Pan Barnet events. We're very happy to be joined by Dr. Devon Patel today, who is a consultant cardiologist from Barnet Hospital, and he will be giving us an update from the cardiology department, and in particular we're focusing on cardiology complications of COVID and cases that he's seen through Consultant Connect. I can also see Amit Bakai has logged on as well, so welcome to him as well, and thanks. Thanks, Devon.
Pleasure. Anisha, can you hear me all right?
Yes.
Okay, great. Thank you very much for the invitation, and it's very nice to meet up virtually with a lot of friends over the years. You wouldn't believe it's over 21 years since I've been a cardiologist in the Barnet area. Anyway, without much ado, the discussion today is really going to be about two things: COVID and the heart, which I'll really touch on. We can have a conversation afterwards if there are any particular issues, and then Consultant Connect, which I think is a very promising new service, which is just bringing GPs and the specialist services together again. And then we'll talk about some themes that come through the Consultant Connect, which I think are probably what you would guess anyway, but it's quite nice to see where the common themes are, but where the questions are coming from primary care. Next slide, please. So the complications of the acute or the severe COVID patients are now very familiar to us. It's thrombosis, widespread, pulmonary emboli, acute STEMIs without any plaque rupture, heart failure with myocarditis being a big prominent component, acute respiratory distress causing heart failure with right heart failure, the consequences of pulmonary emboli and sepsis, and consequent upon this, arrhythmias. Arrhythmias are not per se a primary complication, but it results from the preceding complications. Of course, primary amongst that is respiratory complications and acute kidney injury related to cardiogenic shock or the acute cytokine storm. I won't dwell on the slide too much here, but the mechanisms of myocarditis, heart failure are illustrated here. We've seen quite a bit of acute coronary syndrome work coming throughout the peak of the pandemic. And in many of these patients, there's huge amounts of clot in the arteries and no obvious plaque rupture. And then by contrast, our conventional patients would also develop thrombosis in situ in moderate lesions as well. So really quite a gamut of reasons why both the combination of direct infection and the cytokine storm causing an acute cardiac presentation. Next slide, please. Again, most of this data is now familiar to the older patient, the males, the patients who are obese, the BAME group, patients with pre-existing respiratory disease, immunocompromised, diabetes. So really, it's a fairly standard group of patients who get into trouble with COVID and the heart directly as well. Next slide, please. In terms of some of the clues that we had, so we saw troponin elevation, and I'll show you in the next two slides, BMP and D-dimer. And even small troponin elevations were present in patients who had severe acute COVID, either as an acute stress to the heart directly or some form of direct myocardial damage. It's difficult to be certain always what was the mechanism of it. But in the prognosis, as you can see on the slide, from admission to impending death was a gradual rise in troponin. What we also saw was those patients who left hospital, and by the time of leaving it, the troponin rise had come down quite significantly. So troponin just was a biomarker showing us the acute cardiac stress and some direct cardiac involvement in the group of patients. Now, where does troponin sit with primary care is more difficult to be certain about. Next slide, please. Similarly, pro-BNP, you can see again almost an exactly similar pattern that as you got to the point that you were potentially going to die, you had quite a dramatic rise in troponin levels, which we're not seeing normally in heart failure, up to 40,000 at times in this group of patients. And again, you can see on the right-hand graphic, and during hospitalization, there was a rise in troponin, and then by the time of discharge, the troponin levels were coming down, reflecting a combination of acute cardiac stress from the respiratory insult as well as direct myocardial damage. Next slide, please. D-dimer has been obviously talked about, and we saw quite a lot of spontaneous thrombosis in situ, even in the pulmonary vasculature without a deep vein thrombosis. It was generally associated with quite a poor prognosis, and we've taken to a fairly aggressive management strategy in the hospital of anticoagulating many more patients than we were normally doing so. The management of the thrombi subsequently was fairly standard and nothing new that you would not be aware or familiar with. Next slide, please. I think, again, we've gone through this as a hoop. As you can see on the left-hand side of that line of one, there was potential benefit in the patients who are receiving ACE inhibitors, a neutral effect on ARBs, and curiously, statins seem to be protective to the patient as well. We think that might be an anti-inflammatory effect. We just don't know. And the data is fairly accurate because all of the other markers were showing a higher risk, as you see, as you go up the scale from smoking up to underlying coronary disease and COPD. Next slide, please. And when we saw patients, we often saw more than one thing wrong with the patients. This is a patient with acute COVID. The ECG shows anterior segment elevation from V3 up to V6 and lesser changes inferiorly. And what you can see in the coronary angiogram, the black marker is thrombus sitting in the LAD, and you can see in the mid-LAD in the red marker, complete occlusion of the vessel. Next, I hope that's clear to everybody. Next slide, please. In that same patient, on the right-hand side with the CT aorta, where the star is, you can see a thrombus within the descending aorta anteriorly. And on the right-hand side, you see filling defects where the red star is in the pulmonary vasculature, showing pulmonary emboli. So this patient had thrombus in the coronary arteries, in the aorta, and thrombus in the pulmonary artery as well. Next slide. This is one patient. MRI was, despite the difficulties in doing MRI proved to be a very useful tool in our patients to try and distinguish between acute myocarditis and myocardial infarction. So here is a patient who's got really no significant ECG changes that are of importance. They had a troponin rise, and you can see in the middle graphic and the right graphic that there's a white shadow, which is the edema you see associated with myocarditis, and that on a color-coded slide shows better as being quite a dramatic area in the posterolateral wall. Next slide, please. Here again, a patient with quite severe COVID infection with a minor troponin rise. There's nothing really wrong with that ECG at all. So you would not normally think this is an important one, but this patient had cardiac risk factors. He was diabetic and hypertensive. And on the next slide with the MRI, we can see there's evidence of quite marked ischemia as well as myocarditis. So you can see on the left-hand graphic, there's edema with the white markers in the top left and the middle of the 9 images. And then when we stress the patient, you can see a lack of blood flow showing up quite dramatically in the patient. This patient turned out to have severe LAD and circumflex disease And the question was whether that was pre-existing or exacerbated by the impact of COVID-19. Next slide. In terms of what we did with these patients was really conventional. So as they left hospital, they had acute coronary syndrome management, which was trying to avoid stents in the patients who had very extensive thrombosis. We were using antithrombotics as prophylaxis in many more patients than previously. In patients with heart failure, we realized that overdrying the patient out, which is a conventional way of managing heart failure, was not particularly good. They did better with a bit of more volume loading. We're using ACs and ARBs in these patients normally. Arrhythmias were managed and blood pressure in the normal way. And we supported the patient beyond the acute phase with telephone and heart failure specialist community support, which I think worked really very well for these patients. Next slide, please. When we turn to primary care and the patients who are sitting with you, what tends to come through as themes, as I've discussed with a few GPs, and I'm sure many of you have seen this already, poor effort tolerance, persistent breathlessness, constant fatigue, low mood, a degree of anxiety surrounding the symptoms with an unknown quantity saying there must be something wrong, palpitations, tachycardia or excessive tachycardia and exercise. And I've had a few patients who describe chest heaviness, which might possibly suggest angina, but they are 30 years old, they have no other cardiac risk factors as such. And dizziness has been rather a non-specific symptom in these patients. Next slide, please. So a large amount of that symptom complex is really not an objective change in cardiac parameters that we'll be looking at. So these patients have had prolonged hospitalization, they've maybe disconditioned, they're certainly anxious. The things to look out for as a problem is hypoxia. So hypoxia and exercise, I think, is a very useful tool to tell you where you are. If they're getting a tachycardia, if they have an irregular pulse, we might consider AF or flutter as a secondary consequence of COVID. If you have an abnormal ECG, particularly if there are new ECG changes, that could be a significant finding. And I think it'd be reasonable for you to check a BMP in this patient or a CRP to see if there's anything ongoing. And of course, looking at their respiratory side, chest X-ray in that context. Obviously, the patient has a high cardiovascular risk profile, would be at a high risk of more significant complications. This is a slide that Hannah Jarvis and Amit Bakai have worked on to work out how do you manage patients who are not actually admitted with COVID. And there's a good advice and guidance line supported by urgent assessment in secondary care. And I would suggest that on the top bit, I would include you measuring pro-BNP. There's nothing wrong with doing so. We certainly check it. We look at chest X-ray, look for hypoxia. And if the patients are reasonably well, they would go down to a physiotherapy rehabilitation strategy, or we might just arrange a 3-month review for reassurance. And ultimately, the more complicated patients would have more specialist support with either ILD, pulmonary hypertension, general respiratory, or cardiology, or indeed palliative care in a small number of patients. Next slide. So I think I'll pause at COVID. I think it's a difficult area. We don't know enough about the reasons why these patients are tired, lethargic, tachycardic. One wonders whether there might be myocarditis, but I don't think there's any data currently suggesting that we should be doing widespread MRI scanning for these patients. So I would use the BMP as your marker. If it's up, think about the patient having problems. If it's normal, try and reassure the patient there's nothing too much to be concerned about. So Consultant Connect is a, next slide please, is an app of a software platform which has been around for about 4 or 5 years. The aim of the app really is to give you back the ability to contact the consultant directly, either by telephone or by messaging rather than using the ERS service. And they have a fairly simple mechanism by which you have a single number you phone, decide on which specialty you want to engage with. Currently, in our sector, cardiology and respiratory are on board. Gynae, dermatology, and ENT are considering this as an option. And you can basically dial a number. There are 4 or 5 consultants, which I'll talk about in a minute, who have the numbers. And it just cascades through from one number to the second to the third to try and get a consultant linked to you directly. And once you have that, you have a conversation with them, and that conversation is recorded. It's secure and stored, so if there's a medical legal issue which came subsequently, or you wanted to go back on the information, you could do so forever. We are currently offering the service in the weekdays 9 to 5, which seems to be reasonable. Most of the times when you phone us, it's usually in office hours. So I would say early morning calls are quite common, between 10 and 12, and then between 2 and 5 o'clock will be the next time frame. Very few phone calls come at 9 o'clock in the morning or 5 o'clock in the evening. The second format is just a messaging service, a shared platform. So you upload your clinical data and your graphics, photos, PDFs, and we would respond back to you with a query and have a two-way conversation on SMS. The advantage is that I can do it on my mobile phone anywhere I'm sitting. It's a very easy app from a consultant point of view to use. It works very well on a laptop, and there aren't the usual difficulties in accessing with smart cards, NHS cards, etc., which make life somewhat difficult. We often extend that to sometimes if it's a patient I'm aware of or directed to a consultant who might be there, we might direct that referral inwards to the right person as well. What it's not really set up for is urgent admissions or urgent queries about an acute patient. It really, that is still a hospital service. You phone the registrar on call, the consultant on call, and that remains the setup. And neither does a consultant take any responsibility for arranging an onward test or referral. We do that on an ad hoc basis, but I think the onus is left with the GP to manage that rather than the consultant, to keep it a very clean, simple platform that would work. Next slide, please. Currently, the service has been running for about 6-7 weeks. At Barnet, Amit's been on the national panel for Consultant Connect for some years. Someone's got there's a horrible feedback loop coming through. Joseph Devar, who's at the Royal Free, Robert Greenbaum, and myself. The reason why Joseph, Robert, and myself got involved was we were shielding at the time. It was very easy for us to deal with the problems, and gladly now all of us are back at work in a full-time capacity. If any of the four do not answer the phone, there's a national setup which will answer. That means anyone in the country would answer. It's a paid service for the consultants who do the work, and for the CCG, I think it's a £24 cost per interaction for a consultant, either SMS, rather messaging, or by calls. Our plan, I think with 4 people, we just suddenly found that with holidays looming, we're getting busier with our clinical work streams. 4 is not enough, and probably 6 to 8 with the optimal number of consultants. Not all 21 of us. I think that becomes too fragmented. So I think 6 or 8 will be the optimal numbers we'll be running through to try and run the service more efficiently. To date, in terms of calls, we've had 100 calls, ranging from 1 up to 8 calls per day, typically 3. Out of the 4 consultants, 87% responder rate, 13 have gone to the national team. Very quick services. You get an average response time of 23 seconds, a median of 15 seconds, and up to a minute and a half to respond for a patient. So that's a pretty smart and quite quick service. You're not hanging on for hours like you would normally do for the main switchboards of the hospitals. Typically, the phone calls are lasting from between 6 to 7 minutes. There has been one phone call for 30. I don't know who that was. That's a huge duration of time to talk to someone, but maybe they're a friend having a chat about something else. I only know the call times. 30 minutes is a long, long time. 32 practices have engaged so far in doing the work, some more than others, of course. So the median per practice is 2, and some practices have taken it on board much more so than others. Next slide, please. In terms of comparing this to a more mature service in the South East London Trust, 52 calls monthly, so about 3 per day on the weekdays. They have a 92% local responder rate. What is interesting is their call durations are much, much shorter than ours at 3.5 minutes. I'm not sure whether we chat for other reasons. Our patients are more demanding. It's a new service. We're taking a bit longer. The national average, I think, is about 6 minutes. Next one. I don't like this data. This is a forced data by the Consultant Connect app. It gives you only 5 choices of saying you've avoided admission, you've advised admission, you've requested diagnostics, referrals, etc. So actually, a lot of this is not actually admission-related advice and reassurance, confirmation of what you want to do, rather than you would refer the patient. You would normally just carry on managing the patient yourself. In a few, you might have referred them. In a tiny minority, as you can see, you might have considered admission, and quite a few, I think you might have done a test. So I think, truthfully, I think this doesn't give us the true picture, but what we're doing is a support service for the GPs to manage their patients, manage our patients indeed. Next slide, please. In terms of messaging, we've had 75 messages to date. The median response time, which is quite impressive for a text-based service, is 46-minute response time, median response, 46 minutes, mean is 6.5 hours. But as I found looking at the data in the last, I would say 3 weeks, we've started to stretch out because a couple of people have been on holiday, we're all now working, and the longest response was 5 days. Hopefully we could try and maintain a 24-hour turnaround for most of the inquiries which come through. 28 practices are using us, so a practice is keen and engaged. I won't name individual practices. It was 10 messages down to 1 at the lowest, and average or median of 3 messages per practice. And again, the outcome data I think is probably not that useful. I think probably it's true that you might avoid a referral, but I think mostly it's giving you support to manage a patient and some advice and reassurance. Next slide. What are we seeing? So this was quite a lot of work to try and work out. The app does not give me the data. I have to go through it line by line. And in terms of the messages, which are easier to access, you can pretty much see a theme coming through. So a large number of patients, if you take dizziness, syncope at the bottom with palpitations, ECG tape, is arrhythmias. So arrhythmias probably represent the single biggest area that you are asking questions about, either arrhythmias or what does that ECG mean? What do I do with that? Second commonest is chest pain. And then after that is drug therapy. I thought it's quite a few queries, more than I represented here. And some of this is around breathlessness in a patient with heart failure. Some of the inquiries are really quite complex. So there's an inquiry about carcinoid syndrome, which Joe thankfully took on board. He's a subspecialist interest of his. And some of the inquiries are really very straightforward and simple. I would say none of the inquiries were trivial, and I would say, why the heck did the GP refer? I thought they were actually quite good referrals. Sometimes the graphics did work, so once or twice, a photo you might take from your phone sent up isn't a good enough image to interpret, but by and large, I think the system worked very well. Next slide, please. So just turning to a few cases here now, I've just got 3 examples of patients. This is a patient who was breathless after an MI, so 61-year-old with a STEMI, who's had a stent, who's now complaining of fatigue, breathlessness, tachycardia, although the baseline parameters were very good. As it happened, the patient had COVID, which puts something in the mix. GP arranged a 24-hour tape and an echo, had already said that to me, hadn't actually got the bookings done, and just asked the question, what do I do with this patient? Do I need to do any bloods for the patient? Not. So the possibilities to consider a patient like this is, of course, left ventricular impairment. It depends on how bad the impact was originally. Ticagrelor in about 17%, 1 in 6 patients, can cause breathlessness. Beta blockers, of course, can cause breathlessness, but it will not cause a tachycardia. The patient could have residual ischemia, which is causing a problem, any progressive disease. But there was no chest pain on this occasion. It could be other pathology, so COPD, asthma made worse by the beta blocker, COVID-related, of course. Pulmonary embolism can occur after an MI. The patient could be simply anxious, physically deconditioned, that has been exaggerated by the impact of the MI. Next slide. So what I suggested for this patient was simply first check the oxygen saturations at rest and with exercise. If you see a patient desaturating, you've got a serious problem. If the patient is not desaturating, it could be cardiac, but it rules out the respiratory side of things quite well. Clearly, the heart rate does not pick up much with exercise, then maybe they're over beta block, simple as that. Consider reducing the medication. I would try switching from ticagrelor to clopidogrel, but give it maybe 2 weeks or 3 weeks. If the patient does not improve by that change, I would switch back because ticagrelor has better data in terms of stent thrombosis. If the oxygen saturations have dropped, as I said, I would consider respiratory cause for the patient or decompensated heart failure. I don't think this patient, either a repeat tape or an echo, is all that useful at this point in time. And by and large, certainly at the moment, there's quite a delay getting direct access investigations anyway. So look back at the report, the discharge summary. Was the LV good after the MI? Was there a small cardiac enzyme rise? If that was the case, it's very unlikely the patient would develop further LV deterioration as a late phenomenon. Check a pro-BNP. It's an easy test to do. If the pro-BNP is high, you know there's a problem. If it's low, you can be pretty sure that you're not dealing with heart failure. So I think there are a few clues in the information there, and this was my advice to the GP, to don't bother with the tape and echo, do a BNP, and just look at the patient again. I've not had a feedback yet about what the outcome was. Next slide, please. Next slide, please. Next slide.
Hani, are you there?
Yeah, okay, lovely. Thank you. Okay, so this is a patient, was quite an interesting one, 76-year-old patient with a known small cell cancer from 2 years ago, which was quite stable. The GP noticed a pulse of 3842, but this has been present for about 3 years. The patient had no symptoms really, but had a fall. We don't know why the fall had occurred in a relatively old person. And quite recently, the GP did a tape. The tape showed 40% ventricular ectopics, which is a very, very high frequency. I was just talking to a patient early on today on our remote service, and I said that, look, if you have something like 2%, 3% ectopic beat sets, we don't get out of bed for that. 11% certainly is considered to be quite significant, so 40% is pretty spectacular. Now, when you have, in that tape also, there was frequent short runs of nonsense VT evident. I'm talking about 3 beats, 4 beats, not 10, 12, 15 beats. Now, one aspect I explained to the GP was that actually when you have a high frequency of ectopic beats, the pulse output is low. You don't feel the actual ectopic beat. Of course, the rate is running at 78 to 80 beats per minute because of the ectopics, but you only feel the pulse, and that's going to be running at 3842. So if you have a patient of a slow heart rate like that, an apparently slow heart rate irregular, take the apex rate. We always talk about the apex rate by auscultation. You may find that you hear many more beats than you apparently see that. So simply because the ectopics don't generate a large enough output to create a peripheral pulse. In this patient, my advice was to first rule out electrolyte derangement as a cause of the problem, to check magnesium, potassium, calcium levels. We need to think about an echo to see if this patient has poor LV function. I didn't have enough further history here. Patients with hypertension often have quite a high frequency of ectopic beats. Consider underlying coronary disease, consider a single focus. So if you have multifocal ectopics, this implies a diffuse myocardial problem. If you have a single focus, it might just be one area just throwing off a high frequency of ectopic beats. And I suggested trying them a beta blocker despite the apparent slow heart rate at 2.5 milligrams increased to 5 if tolerated. And I felt that this patient needed an urgent cardiac review with an arrhythmia subspecialist to decide on how to manage them further. But the facts are they've had it for a few years and they're not really very symptomatic. So I suspect it's not quite as worrisome as it suggests. Next slide, please. So this is a very classical type of ECG. You have a patient who's having an operation, has it for a hernia repair. The ECG is reported as showing an MI, an AF patient. And they've had a history of an MI and on a fair dose of beta blocker currently. I hope it's evident. If you look at the bottom line particularly, the RR intervals are varying quite a bit in the patient here. And this patient has a flat baseline. When you magnify this, it's very obvious this is AF. So I think one of the themes I've seen is that the ECG quality can give you the false diagnosis of AF. And many a time I've seen ECG machines falsely diagnose AF when patients in sinus rhythm, and it's very difficult for you to be certain. I've had at least 2 patients who have said don't anticoagulate because you don't have the evidence of AF, even if the machine suggests in the patient's had an irregular pulse. So this patient actually has AF. Next slide, please. So I said there's no doubt about this is AF. Equally, the previous MI does not show up on that ECG, which is a surrogate of saying that the LV function is probably quite good. You might not feel the irregular pulse in this patient because the rate is very slow because of beta blocker. And if the patient has no symptoms from the slow heart rate, I would continue the present dose of atenolol. There's no need to discontinue or tail it down. What I did suggest here is that perhaps a repeat ECG with a rhythm strip might give us a better indication of the rate, or better still, a 24-hour tape. And obviously the patient needs to be anticoagulated. Since it's over 26 years since his heart attack, 36 years since his heart attack, he can stop aspirin and start an anticoagulant. So that's an important consideration here. So for this patient, a very simple advice, and that's definitely an admission avoided in this context. Next slide, please. So I think that's a sort of a quick summary through Consult Connect. I'm very happy to take questions and discuss either the COVID scenario or the Consult Connect service.
Brilliant. Thanks so much, Devin. That was very helpful. It was good to hear about how you're managing your post-COVID patients and your tips about BMP, and also the kind of cases that you're seeing on Consultant Connect and your very quick response time. So thanks so much for that. I can see Amit Bakar has been addressing some of the questions on the chat, so thanks for that, Amit. Devon, we'll give you a very quick breather, because the first question is for the Federation, if that's okay, and then we'll move on to cardiology.
Yeah.
The first question is from Silvana, who says, could I just clarify what is the criteria for the AAC home visiting service? Is it for suspected COVID or excluding suspected COVID? Is it for practices who do not have capacity to visit themselves? So Anuj, I don't know whether you have a comment on that.
Yeah, so the current AAC home visiting is for COVID patients, suspected COVID patients only, not for routine home visits. And the criteria we're working on with the other federations to have something across pan-NCL in due course. But essentially, if you follow the current guidance in the pathways we designed when the AAC was first introduced, that will allow that. It still goes through a triage by a senior clinician before a home visit is authorised anyway. So just to let everybody know.
Yeah. Okay, thanks, Anuj. I think there was a comment from Joanna Webb about the care home supervision sessions. Joanna, I have posted the details from the Training Hub onto the chat. So please just use that for the care homes. You can contact me. So moving back onto cardiology now. We have a general question, actually, first of all, from Stephen Corcoran, which is not in the chat, which is about ECGs in our psychiatry patients. And he talks about calculating the QT interval. A lot of our ECG machines can't calculate the QT intervals. And sometimes the psychiatrists don't have a consistent approach with regard to the ECG results. So he's wondering whether there should be a central allocation for ECGs with a clear sort of protocol about what to do when patients are on relevant drugs that can prolong the QT. Do you have any comments about that, Devon?
I think firstly, don't worry about the QTC being slightly prolonged between 450, 460 milliseconds. In fact, in women, up to 470 milliseconds. Where it starts to become an issue is when it's more than that, or if the patient has arrhythmia. So I think a simple issue is to look at that. The other thing, a little tip is, look at the ECG. The T waves are very, very flat. It's impossible for the machine to get that number exactly right. So there are simple tips of saying you might just get that wrong. If you have an old ECG for comparison, qualitatively look at that and see if there's a difference or not. Notwithstanding that, I think Stephen's point is very valid. Consultant Connect showed the same issue, that psychotropic drugs and QT intervals were coming up as a theme in this context as well. So that's in the broad bundle of ECGs. And I think there isn't a simple answer, but I don't think the patient needs to be referred in to us. Use Consultant Connect. I think it's quite a good model, or ERS, saying, are we reassured this ECG is fine? Can we ignore it? And I think it's a clinical decision to be made based on comparative ECGs and someone looking at it. I think it's very difficult, the ECG getting right. I do think that, however, there's probably quite a lot of referrals with a QTC of 445 or 50 milliseconds, which I think you can sit tight on.
Yeah. Okay, thanks, Devon. Amit, did you have a comment about that? I think you put your hand up.
Yes. Thanks, Anisha. Just to say, as Devon has said, it's a tricky one, and it's good to use Consultant Connect. The polypharmacy work you're doing with Clifford Lisk, we've actually built a program of work for our pharmacists and our anaesthetists and our psychiatrists as to what we do with QTC. So there is a cardiology framework teaching that we can supply. So I've got a beautiful deck that says if it goes over 60 milliseconds, or if it, within the 1 month time frame, or if it goes over 500 milliseconds, those are the patients that we need to worry about, which drugs have the highest frequency. So we can, I can speak to Famida about that if that's useful.
Oh, that would be really useful. Thanks, Amit. That would be great. Moving on, just in this time, we have a comment from Oggy, which I think Amit has partly addressed. So thanks for that. But she says, Consultant Connect has been great. I've had an excellent comprehensive response back from cardiology, but part of the reply back was to send an urgent echo and 24-hour tape to Barnet preferably, which was subsequently rejected as they were not yet receiving direct access requests from GPs. So I know, Amit, you've written an email address to contact about that. So thanks for that. Do you have any comments about that, whether they will be, because there's somebody else, I'm not quite sure who that is, OLMC guest has said, when are we planning to reinstate direct access investigations?
Okay, can I try and answer that question slightly? So I think there is, currently it is a pilot service, And one of the advantages of Consultant Connect is if that is mentioned, the name saying discuss with consultant X, Y, and Z, and has advised this test, that should go through. The trouble is that the restrictions of testing have been quite significant for echo tapes, etc. So we've switched off direct access at the moment. We just feel that at the moment, and I would say probably for the next 2 to 3 months, we still won't have access to that. I'd suggest use InHealth, and we can look at the data from InHealth if you have that available at the moment for you. But we will switch it on. I think Sue is an example, she will do so. But if you refer directly to her, she may well reject the referral. So I think if it's an advice given by a consultant saying, look, actually, I agree, this probably needs to be sorted out by a test rather than a referral, we'll do so. But it's not a gateway for every direct access request. So I think we just have to have a much lower, higher threshold before we request a direct access investigation here or a query.
Great.
And we are restricted ourselves in trying to offer that. For example, stress echocardiography at the moment has just been switched on for a very limited number of patients. We've got a problem here.
Yeah. Okay. All right. Thanks, Devon. That's useful. And there was a comment from Andrew, which I think Mimik's already addressed, about presumably a Consultant Connect is for anything cardiological, so any general inquiry, which it is. Then Diane says, do all hospitals have post-COVID clinics? Is there a special referral form? So I don't know that's a general question, not just for you, Devon. But I didn't really, yeah.
I think there's Hannah Jarvis has led on the service there. So there is a system set up. I'm not sure if they communicated to you directly, but there is a process by which you can refer directly. I don't know whether there's a form or not.
Yeah. So she has actually spoken to us before via Simon Brill, and it's actually they receive referrals via a mobile number rather than a form at the moment, as far as I'm aware. Yeah.
I'll feedback. I think there should be a process of referral for that.
Yeah. I can post them. I can post them mobile in the chat for now. Brilliant. So I think we have addressed all the questions that we have on the chat. If anybody has anything else, please post now. But Charlotte, I wonder whether, in the interest of time, we should think about wrapping up. We've already taken up.
Thank you, Anisha. Thank you, for organising it so brilliantly. Lovely to see our colleagues in cardiology here. So really thank you to Devon and thank you to Amit. That was really interesting. The cases were fascinating and lots of really helpful information. And we are fortunate that we have access now to Consultant Connect in Barnet. So that was great today. So thank you very much. And thank you to Suzanne and thank you to Anuj for the earlier updates. The next meeting, which is in 2 weeks' time on the 2nd of September, we're going to have a mental health update, which is what was requested at one of the previous meetings, updates on what's changed during COVID and changes to referral pathways in the mental health services. If you've got any questions that you'd like to submit beforehand, then please email Anisha or myself or anyone else in the primary care team, and we will submit those questions. Otherwise, really look forward to seeing everybody in 2 weeks' time. And I hope those of you that haven't yet had a holiday manage to have one in the next few weeks, and hope it doesn't get too busy come the start of September. Lovely to see you all and have a good afternoon.